Thank you guys for joining me today for this roundtable. And today we're going to talk about the emerging data we have for long-term treatments of anti-VEGF therapy. We'll touch on some of the more pivotal clinical studies. I'm going to have each of you lead some of these studies and talk about them and what they mean to you in your own practice and what you do with your patients. And we'll focus on the outcomes of this data and sort of what the best practices have evolved as a result of looking at some of this data. We're going to talk about the View 1 and View 2 extension studies, the 7-Up trial and the range studies, and then we'll also have some expert case presentations given by each of you at the end of this program. So we have a variety of data that's come out about long-term anti-VEGF inhibition for AMD, and we've seen improvements from the initial studies of 1 and 2 lines sort of degrade over time in many of these trials. We've have multiple approved anti-VEGFs at this point and some that are used off-label currently. And then there have been really few studies on long-term outcomes. We only see about 4 or 5 good studies out there with prospective data on this indication. We know that obviously there's been a breakthrough therapy in the treatment of patients. When we first started in this condition, and treating this condition many years ago, I don't think any of us would have expected the results we saw recently with these patients. So this has really been quite a breakthrough therapy. And we're going to start with some of the questions for you as far as your patients go. So let's start maybe first with Diana. When you talk about the patients you have, do you think that the majority of patients will require treatment indefinitely, or do you think that they sort of burn out over time?
I think in my experience, a neovascular age-related macular degeneration is a chronic condition. Although some patients may not have active disease that requires monthly therapy, they do require a lot of follow-up because sometimes even in the 3rd and 4th year, they still have bouts where they'll have edema, subretinal fluid, or even hemorrhage. So they will never be, I think, disease-free, but I think the interval of follow-up might be extended.
Kwan, you've taken care of patients for a long time. Is this really a chronic disease, or do you feel like at some point you can arrest it in some state that doesn't require additional therapy in your patients?
Well, certainly our data so far have indicated that it is indeed a chronic, although we define how long the chronic is, but certainly we're talking about years here. And Diana was mentioning the number of patients who need treatment over years. Yes, they may need fewer treatment in 1 year versus another, but certainly it's not something that we can say to the patient, oh, you will get it cured within a year or 2. Definitely not. And certainly looking at some of the data have been seen that some of the patients, even from some of the very original anti-VEGF study, are still requiring treatment now, 8 years, 9 years out after that. The number of treatment may vary, but I certainly would classify this as a chronic disease.
We have a variety of different mechanisms we treat these patients by. We have monthly, treat and extend, PRN, and the majority of retina specialists do a treat and extend regimen. What do you think about some of these practices, and what do you do in your own practice right now for treatment?
Well, clearly, I think we know that monthly therapy, at least early in the course of treatment, is the best option for most patients. For me personally, once we get through that initial phase where the disease is under control, the retina is fairly dry, or at least as dry as it's going to be, then I'm a pretty consistent treat and extend management. So for me, I treat these folks with extended intervals, but move the intervals very slowly so that you can pick up disease activity early in the course of a recurrence. So, but I think treat and extend really offers the best opportunity to catch early disease activity and maintain visual acuity gains.
One of the pivotal questions about treat and extend is what interval can you achieve? So what interval on average do you think you achieve with your patients between injections?
Well, so if you come to my clinic and you see 10 patients, you're liable to see 7 or 8 different intervals. But I think a lot of patients, though, sort of end up falling into the 7, 8 week range once you get their disease under control and you've maximized their extension time. So every patient's a little bit different. I really do think this is personalized medicine in the chronic phase, not in the acute phase, but in the chronic phase. But by and large, it seems that patients sort of level out at the 8-week phase with anti-VEGF therapy.
What's your longest interval that you have extend patient out now?
Well, for me, if I go out past 12 weeks, I'm either going to leave them at 12 weeks or I'm going to give them a chance to come off therapy. So for instance, if their second eye this is their first eye, their other eye is fine, I'll often give a patient an opportunity to come off treatment. But 12 weeks seems to be the longest, and I guess that's just based on some of our experience in well-controlled clinical trials. We really don't have good experience in treating patients in age-related macular degeneration, at least, greater than 12 weeks. What about in your practice?
Yeah, I agree too. I think that I tell myself also too, I don't think I go beyond 12 weeks of that. And even after the 12 weeks period of time, I still have the patient coming back and see me again with that. And I will explain that, Mr. John, for example, yes, we know your disease is stable right now, but there's a chance that maybe bleed, and it's better that we catch that disease should they recur earlier rather than later. So I definitely would not let it go, like not see the patient for 4 months or 5 months or something.